Hey, future respiratory therapist. So, part 2 of the Tidal CO2 presentation or lecture or whatever you want to call it, lesson, whatever you want to call it. We're going to get that knocked out here today. I'm going to get it posted for you. So, if you remember in part 1, we talked about the physiology of carbon dioxide. And we talked about things that will cause your Tidal CO2 to rise or to fall. And so I want you to keep those things in mind as we go through part 2 of this, because those things are going to become valuable. You need to remember those as you're assessing your Tidal CO2. Now, the purpose of this video is to teach you how to use and to assess Tidal CO2 for clinical decision making at the bedside. I told you in part 1 that proper use of Tidal CO2 can cut down on the number of ABGs you need to draw. And so the purpose of this video is to show you how that's possible. Okay, so here we go. When you're talking about Tidal CO2 and you have it on your patient and you want to know how do I use it, you need to understand, first of all, your normal values. So when we talk about Tidal CO2, this is normal values, Tidal CO2. I got the wrong marker here. Give me just a second. Then we know that we're looking at 35 to 45 millimeters of mercury. Now, right here, I want to pause, because if you go into Google and search normal Tidal CO2, it will pull up 35 to 45. But typically, the Tidal CO2 runs a little less than arterial CO2. So typically 1 to 4 to 5 millimeters of mercury less. So typically when we talk about normal, we're really talking about 30 to 43 millimeters of mercury. Okay, now if that's normal Tidal CO2 and we're going to use this, and here's what I'm going to tell you, because there's a very slight discrepancy here, that doesn't even matter, because I'm about to show you how your Tidal CO2 value that you see on the screen doesn't even matter. Okay, I'm going to show you that here in just a second. We know that normal PaCO2 equals 35 to 45 millimeters of mercury. Okay, now that's all fine and dandy, right? Your Tidal CO2 should be very close to and very similar to your arterial CO2 in your healthy individuals. But we typically aren't taking care of healthy individuals, we're taking care of sick individuals. And so this gradient becomes larger, not just because of the disease process, but also because of the dead space from then the tracheal tube and the circuit inline taking care and delivering air to and from the patient. So it's not going to be identical, okay? Now, what I want you to understand here, I'm going to erase this because we know our normal values now. So let's get this off the board, and let's talk about what really matters. And if you're taking notes, this is what I want you to write down. What really matters is the gradient. This is the difference between arterial CO2 and Tidal CO2. So it looks like this. And all this says is we're talking about the partial pressure of CO2, but we're going to talk about the difference between arterial and Tidal CO2. So you simply do this. Now, how do we get our gradient, Joe? It's very, very easy. When you draw a blood gas, you note what your Tidal CO2 is. This is where you should start. So anytime you're taking care of a mechanically ventilated patient, and they have an Tidal CO2 running, for you to be able to utilize that number in an effective way, you have to understand how that Tidal CO2 correlates to your arterial CO2, and we call that the gradient. So what you do is when you draw the blood gas, you note what the Tidal CO2 is at that time. Now, when your blood gas comes back with a PaCO2 that equals, let's just say 45, and you have an Tidal CO2 that comes back at 40, then you know your gradient is 5. plus 5, which means that if you add 5 to your end-tidal CO2, it will be approximately what your arterial CO2 is. Now this is important, okay? Because an hour later, you're taking care of your patient, and an hour later, maybe they start spontaneously breathing, or maybe they don't. It doesn't matter. But you see, so remember this, we're talking about gradient, okay? We're talking about the gradient between arterial CO2 and end-tidal CO2. That's what's important. We have a gradient of plus 5, which means that your end-tidal CO2 is whatever it is, you're going to add 5 to it, okay? So if your patient in an hour or an hour and a half or 2 hours or 30 minutes or whatever it might be, if their end-tidal CO2 is 30, if we add 5 to that, then we can approximate that our arterial CO2 is approximately 35. Why? Because we know that the gradient, the difference between arterial and end-tidal based off of the blood gas that we drew an hour ago, had a gradient of 5 difference. So we simply add 5 to our end-tidal CO2, and that'll give us an approximation of what our arterial CO2 is. So my point is this: end-tidal CO2 tells you nothing unless you know your gradient. So let's say you come into your room and you have a patient who has an end-tidal CO2 that equals 20. Now, if you don't know your gradient and you don't know anything about your patient, then you don't know if that's telling you that your arterial CO2 is approximately 25 or maybe approximately 50. You don't know because you don't know what your gradient is. See, if your gradient was plus 30, then you have a CO2 of approximately 50. If your gradient was plus 5, like in the previous example, then you have a CO2 of approximately 25. This makes the gradient the most important part in understanding how to use end-tidal CO2 at the bedside, just like you use pulse oximetry. You wean down FiO2 from a SAT of 90, you have an SpO2 of 98%, so you turn the FiO2 down from 60 to 50 and it goes to 95. You still don't know what the PaO2 is, but you turn it down to 40 and it drops to 90. Well, at 90, we know that our PaO2 is approximately 60. So we can use that as a reference point, right? Non-invasively. I don't even need a blood gas to assess oxygenation. I know that if I have a SpO2 at about 90 to 92%, I can estimate what my arterial oxygenation is. This is how we use end-tidal CO2 to approximate what our arterial CO2 is, okay? Now, the second thing you need to know, after you understand the gradient, you need to understand that end-tidal CO2, I told you the number means nothing. What matters is the movement of the number. Does the number go up or does the number go down? Because this is how end-tidal CO2 works. It works, excuse me, it's an amazing trending tool. So you have to understand that you can use this tool to trend rises and falls in end-tidal CO2, which are a reflection of rises and falls in arterial CO2. Okay, so let me do it like this. You have PaCO2 here. You have end-tidal CO2 here. Now remember, they're relatively close in the normal healthy person. But even if they get further apart, they still should move in the same rate, same direction, except for one disease process and one problem that I'm going to tell you about, okay? But for right now, what we know about arterial CO2 and end-tidal CO2 is that if arterial CO2 goes up, then end-tidal CO2 will proportionally increase. So your gradient here stays the same. Now, if arterial CO2 goes down, you will see your end-tidal go down. Proportionally, your gradient stays the same. The difference between these two is your gradient. And that's how you use end-tidal CO2. If you have a patient with a gradient of 5 and you put them in a spontaneous breathing trial and your end-tidal CO2 creeps up to 50, then you know your arterial CO2 is approximately 55. This person is probably going to fail that spontaneous breathing trial. If you put them in a spontaneous breathing trial and end-tidal CO2 goes down, then you know that your arterial CO2 is probably going down. Okay, so that's how the two work together in trending changes in your patient. Okay, now let's talk about the oddball. There is an example and there is a scenario where PA CO2 goes up and end-tidal CO2 goes down. And this is in the presence of increased dead space. Now, what would cause an increase in dead space? I'm not talking about a stable dead space such as emphysema. I'm talking about suddenly you have a rise in your CO2, but you have a decreasing end-tidal CO2, so your gradient now is getting larger. You can see here where your difference here is much smaller than your difference here. So this is an increased gradient, increased from the initial gradient. And the answer here is the presence of a developing pulmonary embolism. Okay? Now there's one other thing here. A decreasing cardiac output could also cause this to happen. But think about what happens if you have a decreasing cardiac output. You have perfusion going down, ventilation stays the same, and ventilation starts to exceed perfusion. And that's the definition of a dead space. Dead space is ventilation in excess of perfusion. So if your cardiac output goes down, I gave you this example in part one, I gave you this example. We're at the bedside, we turn a patient, their blood pressure begins to plummet. Now we didn't know this because the blood pressure wasn't being constantly monitored. But our end-tidal CO2 rapidly started to fall. So I said, okay, we've either lost blood pressure or we just threw a pulmonary embolism. We monitor blood pressure, and sure enough, the patient has gone from normotensive to hypotensive and rapidly falling. And this is how we use it clinically. So you just have to understand what would cause an end-tidal CO2 to go up or down and be thinking about those things. Now, this is the oddball. Now, so a patient who throws a pulmonary embolism will cause your CO2 will go up, your end-tidal CO2 will go down, your gradient will get larger. Why is this? This is what I want to focus on now, okay? So I'm going to show you an illustration here of explaining how a pulmonary embolism can cause an increase in your gradient, okay? Now this is going to start with normal. I'm just going to draw two alveoli here, okay? And we have blood flow coming by and blood flow coming by, and they all feed in together. And we know that O2 comes in to both of these. And as blood passes by, at this point, O2 goes in, CO2 goes out. O2 goes in, CO2 comes out. And then these alveoli exhale this CO2 and it's measured. And that is our end-tidal CO2. And that is normal. Okay? But what happens when we see something like this? We have a blood clot here. This is a definition of a pulmonary embolism. You have a clot that is obstructing blood flow to your pulmonary capillaries. So the blood is coming here, right? But here it stops because of the pulmonary embolism. So what happens? O2 comes in and O2 comes in. Now here we see, over here on this side, we see that everything normal happens. O2 comes into the blood, CO2 comes back into the alveoli. But over here, O2 comes in, but it doesn't go across because there's no blood flow, which means there's no CO2 that comes back across. So when we exhale, here what happens? Here we get CO2 coming out, and here we get O2 coming out. When you mix CO2 and O2, the O2 dilutes the exhaled CO2 from the normally functioning alveoli. And so this is what I want you to understand. Why does a dead space problem, a pulmonary embolism, cause an increasing in your gradient? And the answer to that is simply this. The exhaled oxygen from the alveoli that is not participating in gas exchange because there is no blood flow. Upon exhalation, that oxygen is exhaled and it dilutes the concentration of CO2 being exhaled from the healthy side. And that's why you get a decreasing in tidal CO2 with the presence of a pulmonary embolism or increased dead space ventilation. Okay, you have got to understand this. You have got to know from a clinical perspective that when you're taking care of your patients and you see a drop in your end-tidal CO2 and you see other mechanisms, tachycardia, tachypnea, they're showing up on your patient. The patient suddenly has thrown a clot and now they're showing signs that something has changed. Then what you need to do is get another blood gas. And what you need to assess is if your gradient was 5, but 2 hours later you notice this drop in end-tidal CO2, but other clinical signs and symptoms saying something's not right, like there's something else has changed, then you need to get another blood gas and you need to assess your gradient again. And when you assess your gradient the second time, and this gradient is now 35, then you understand that your patient has an increased gradient, and that makes you need to think about a pulmonary embolism. Okay? You got to think about this stuff. You also need to assess blood pressure. If you have a dropping end-tidal CO2 with an adequate blood pressure, then you need to be asking yourself, do I have an increased dead space? If you have a dropping end-tidal CO2 with a dropping blood pressure, you need to understand, I have an increase in dead space, but it's because of the dropping blood pressure. And we need to fix that. And when you fix that, it will raise your end-tidal CO2 back up to hopefully to a normal gradient. So you have to be able to think about lots of different things here when you're talking about end-tidal CO2 and how to use it. Okay, we use end-tidal CO2 also during cardiac. Why do you think we use it during cardiac arrest? You use it because if there's no blood flow coming back to the lungs, then your ventilation is pointless. We use it to assess the effectiveness of compressions. So when you're doing compressions on a patient that's coding, and you have an end-tidal CO2 monitoring present, and you're doing compressions, and your end-tidal CO2 is 20, 20, 20, 20. But the longer you go, it starts to drop from 18, 17, 16, 14, 13. You need to understand that the person doing the compressions is getting tired. You see, an end-tidal CO2 less than 15 during a cardiac arrest situation can be used as an indicator to provider fatigue. They were doing really good chest compressions at first. They were circulating blood, and we were getting back an end-tidal CO2 greater than 15. When it drops less than 15, you need to say, hey, you're getting tired, let me jump in. You guys know what I'm talking about. Some of these people try to get up there and do compressions forever. Like, I never get tired. And in their minds, they don't get tired. But we can objectively assess their level of perfusion back to their level of adequacy of compressions with an end-tidal CO2 monitor. So use it in your code blues so that you can assess adequacy of compressions and recognize healthcare provider fatigue earlier so that we can get new people in, new refreshed people that can better circulate that blood. Now, the last thing we need to talk about when we talk about this in part 2, remember part 3 is going to be all over capnography. It's going to be reading the waveforms. But the last thing we got to talk about here in part 2 is how can we use this to assess dead space amount? Okay, and it's easy. There's a formula. You guys know it was coming, right? There's a formula, and the formula is PACO, PICO, this is P, over PACO. So a lot of times you'll just see it as PACO minus PICO over PACO. Okay, now for completion's sake, I'm going to leave the end title in here so you know what this number reflects. Okay, now what this is going to tell you is the amount of dead space that your patient is experiencing. So if you have an arterial CO2 of let's say 40 and your end tidal CO2 is 35 and your arterial CO2, like we said, was 40, then what you have is 5 over 40. Now, when we assess 5 over 40, what we see here, we do this math. I could probably do it in my head, but I'm just going to use my calculator here. 5 divided by 40 equals 0.125. This means that this patient has a 12.5% dead space. That means that 12.5% of your tidal volume is not participating with gas exchange. That's a very minimal amount. And we know that because our gradient is small. But what happens when we have an end tidal CO2 of 15 and an arterial CO2 of 40 and an arterial CO2 of 40? We get something completely different here, right? So when you do 40 minus 15, you get 25 divided by 40, and that gives us 25 divided by 40 equals 0.625. This is a 62.5% dead space. And you need to understand that this is important because if you have a patient who has a tidal volume of 450 mLs, so you have 450 mLs, and you have a 62% dead space, then what this says is 0.625. What this says is 281 mLs of this 450 are not participating in gas exchange. And that's going to be a problem because you're going to have to move a larger minute volume to effectively remove CO2 from this patient because only 62.5% of those tidal volumes are actually participating. Okay, so no, 281 is dead space. So if you do 450 minus 281, that means only 169 mLs are participating. This gives you your dead space. And when you subtract that from your tidal volume, you get your effective tidal volume, or what I like to call with my students, our alive space, the opposite of dead space. Now, don't repeat alive space because it is not a technical term. But I like to get them to think about it in those manners where you go, okay, so this is dead space. It's not participating with gas exchange, 62.5%, which means that 169 mLs are participating, and that's my alive space, okay? Super cheesy, but it works for students to learn and understand what their effective tidal volume is. Because see, when you put in 450 mLs, not all of it is participating with gas exchange because every patient you're taking care of has some element and some amount of dead space. So you can use this formula, PACO, PICO, PACO, to assess the amount of dead space and the amount of tidal volume that you're losing with every single tidal volume. That's how you use end tidal CO2 at the bedside to make better clinical decisions taking care of your patients without having to redraw blood gases every single 2 hours, make a change, draw a blood gas. No, we don't need to draw a blood gas. My gradient was 7 and we increased the rate and it went down from 43 to 36. So gradient was 7, end-tidal CO2 was 43, so initially I was at 50. Now I'm at 43. We're back in normal range. Don't draw a blood gas. You know where you're at. We got to start using this tool more effectively. Okay? That's how you use it. Okay? Remember these key terms. Remember gradient. Remember trending. Remember exhale dilution, which will explain to you why you get a largening gradient in the presence of a pulmonary embolism. And remember PACO, PICO, PACO. If you can remember those 4 things, you're on your way to using end-tidal CO2 effectively at the bedside. Okay? Best wishes, guys. Stay tuned. Part 3 is coming out here real quick. Best wishes.